It is the opinion of those who best understand the physical system that if the physical laws were strictly observed from generation to generation, there would be an end to the frightful diseases that cut life short and of the long list of maladies that make life a torment or a trial. And that this wonderful machine, the body, this goodly temple, would gradually decay, and men and women would at last die as if gently falling asleep. By Mrs. Shedwick. Now, I don't know who that is, but I tell you, she's making a really good point here. And again, this is why I'm so excited about tonight's webinar, because, I mean, just the sheer number of people who are abusing pain medication, I mean, those who are using it for good reasons and those who are abusing it, run into the millions. And, of course, many of us know the damage that can do to different parts of your body, especially the liver and the kidneys, to mention a few. So I am so glad, again, to have Mr. Deitsch on. I'm just going to say a few things about him. And that's Rick you're looking at when he still had his hair. And he is the chairman and chief executive officer of Nutrapharma. Rick Deitsch is Nutrapharma is about biopharmaceutical company specializing in the acquisition, licensing, and commercialization of pharmaceutical products and technologies for the management of neurological disorders, cancer, autoimmune, and infectious diseases. I guess we're going to add pain to that. I'm going to just skip a few things here. He's a lecturer at a couple of universities. He is also the author of 2 books, Are You Age-Wise? A Guide to Healthy Aging, and Invisible Killers, A Guide to Environmental Toxicity. And without much further ado, Rick, are you there?
I'm right here, Dr. Abijabi. Thanks for having me.
Well, thank you for joining us. Well, talk to us about pain. I mean, I can hardly hold myself back. Go ahead. Well, first of all, I just want to clear this up with you. What's the stats on abuse of pain medication abuse?
In fact, we don't even have those statistics because in many cases people are afraid to talk about abuse of pain drugs because they're afraid they won't get those pain drugs. And I'll talk a little bit about that tonight.
Okay.
In fact, it's really kind of very sad that so many people are in chronic pain, and the only thing they can do is take these opiates. And so these pain centers or pain clinics have popped up all over the country like weeds. And only now they're starting to get shut down by attorney general's offices, state by state. In Florida alone, 30 were shut down in the last year, in the last 12 months. Because as far as the attorney general is concerned, it's simply a prescription farm for people addicted to pain medication. Meanwhile, there are people that are in severe pain and they need some sort of alternative. And that's really what I want to talk about tonight.
Great. Great. I just want to mention quickly, too, that you were the one who also brought Detox, the zeolites, the science to market. And I, in particular, have been very, very impressed with that because a lady friend of mine who's had headaches for 47-plus years, and we later on found out that that was due to the silver fillings in her teeth. But with the zeolites, that also helped to, I mean, it just helped to wipe those headaches out. So I was really impressed with that first presentation that you did. But please, let's go on with the pain.
Well, absolutely. And I think it's important to understand that what you talked about earlier is incredibly valid. I believe in a holistic approach. Everything is interconnected in some way. And if you understand the neurologic syndromes and understand how heavy metals can interrupt neurologic signaling, then you can understand that if you use oral chelators like the zeolite, you're going to remove those heavy metals and the body's going to function better. And I'm going to talk a little bit about neurologic signaling tonight. But I could go on and on about how things are interconnected. One of my more recent soapbox issues has been the concept of low-salt diets. So many doctors are telling patients to go on low-salt diets. And, of course, that's a good thing. You shouldn't have too much salt. It does cause bloating. It can cause high blood pressure, especially in people who have cardiovascular risk. But we get almost all of our iodine from salt, from iodized salt. And now we go on low-salt diets. People don't get their iodine. They're becoming hypothyroid, and they're gaining weight because of a slow thyroid or a non-functioning thyroid. And so here they are trying to avoid high blood pressure through a low-salt diet, and they're winding up with obesity that actually greatly increases the risk for high blood pressure.
Right.
So you should understand that everything you do, every decision you make is going to have some sort of consequence, and you should be able to weigh all the risks and have an understanding.
Right, right. That's why we like what you do, because you bring all those things to bear in the whole health equation.
Well, thank you very much. So let's talk about this concept. What is pain? How do we treat pain? And then this very exciting thing, we're launching this new pain drug, Cobroxin. Let me talk a little bit about that as well. So first of all, let's talk about pain in America. Pain is suffered by over 76.5 million Americans. That means 4 out of 10 Americans suffer with pain. 1 out of 10 are acute pain, and that could be, post-surgical. It could be acute because of a health issue. It could be acute because of trauma. You were just in an accident, for example. But 3 out of 10 live with chronic pain, which means that they're in pain all the time. And I'll talk about different types of pain, including head and neck, lower back pain, etc. 50 million people suffer with chronic pain, 10 million with neuropathic pain, and that includes diabetics. Many diabetics who have higher HbA1cs, hemoglobin A1cs, tend to have glycosylation of nerves, which causes neuropathy or neuropathic pain. And now diabetes itself is at epidemic proportions, and so the side effect of neuropathy is at epidemic proportions as well. And so right now there are at least 10 million people with neuropathic pain, including diabetics, and that number goes up every year. The highest number of chronic pain sufferers is lower back pain. 27% of pain is lower back pain, and then 15% is head and neck, and that includes migraine headaches. Again, look at the percentages. Over 42% of U.S. adults with pain are in pain for greater than a year. So once you have that chronic back pain, it's going to last for more than a year. And you simply get used to it. You're popping the over-the-counter drugs. You might be on some prescription drugs, really on a daily basis. The cost of U.S. chronic pain is estimated to be around $100 billion a year. It's a huge market. And then 42 million people lose sleep at least 2 nights a week because of pain. And as I said before, lower back pain is about 27%. Severe headaches, including migraines, about 15%. And then neck pain, another 15% of Americans. Back pain, of course, is the second most common cause for office visits. The first has to do with headache, usually idiopathic headache. 60 to 80% of the population sometime in their lives will experience lower back pain. Now, of course, this is not always chronic pain. This is not always simply chronic debilitation or an effect of aging. It could be traumatic. It could be that you pulled something, lifting a box wrong, for example, like in my image. It could be acute pain from a car accident that has some layover, and it can be neurologic. It can be deep back pain or even surface back pain. But sometime in their lives, as much as 80% of Americans are going to suffer from lower back pain. And each year, 15 to 20% will have some back pain. It is the most common cause of disability for people under the age of 45, and back pain disables 1% of U.S. population. The cost of society being $20 to $50 billion per year in medical costs and lost work. Migraine headaches are another. As many as 30 million Americans suffer from migraine headaches, with about 20% being women. And as you talked about headaches before, a lot of that is hormonal. A lot of the etiology of migraine headaches starts with the hormonal balancing. 7% are men, and most of some migraine manifestations occasionally. So migraineurs might suffer once a month, twice a month, 3 times a month. And what happens is not only do you have drugs that treat the migraines when you suffer them, but many of these people take daily drugs for prevention of migraines. And those drugs can be highly toxic. Some drugs, in fact, are ergot-based, which comes from a toxic rye plant, actually a toxic fungus that grows in the rye plant. And that can cause all sorts of organ failure and tissue damage. And so people should be aware of what they're taking prophylactically, and maybe through diet, through proper health management, they would be able to prevent most migraines and then treat it with something like Cobroxin. So let's talk about the levels of pain. The World Health Organization separates pain into 3 basic categories: Stage 1, Stage 2, and Stage 3. Stage 1 pain is considered over-the-counter pain. That's pain that can be acute, it can be chronic, but it can be treated for the most part with over-the-counter medication. That includes the NSAIDs, the non-steroidal anti-inflammatory drugs like aspirin, which is acetylsalicylic acid, ibuprofen, naproxen like Aleve, and ibuprofen like Advil, and then acetaminophen, which is Tylenol. Then when you kick it up a notch, you get to stage 2 pain. That's pain that either interrupts your sleep and or your work. That's stage 2 pain. There are no over-the-counter drugs for the treatment of stage 2 pain. At that point, you're on at least low doses of things like Percocet and Vicodin and Tramadol, and you could be on antidepressants or Tylenol 3. Then the next level is where it's debilitating pain, and that's where you're usually on injections of things like morphine, hydromorphone. You could be on fentanyl patches, things that deal with absolutely severe pain, which is in many cases in the elderly, post-surgical, or cancer pain, which a lot of these medications were specifically invented for treating the pain due to cancer. Mm-hmm. Now, another way to look at this is what I call the 1 to 10 scale, and all of us have experienced this. You go to a doctor when you're in pain, and the first thing he asks is not, are you in stage 1, stage 2, or stage 3 pain? He says, on a scale from 1 to 10, how would you rate your pain? Okay? Mm-hmm. And when you start talking about it in that fashion, and most of us can easily say, I'm at a 5, I'm at a 6, I'm at a 9, I'm at a 12, if you're in severe pain, most of us could say, well, from 1, 2, 3, maybe even going to 4, that's mild to moderate pain. Then once you get up to between 5 and 7, you're moderate to severe. Once you get over 7, that's severe pain that usually requires some very heavy doses of medication or these injectables. Now let's go over each level and just talk about what the issues might be with them. First of all, with the OTC drugs for stage 1 pain, you have a variety of different NSAIDs, which include things like aspirin, Aleve, Advil, which is ibuprofen, naproxen, and then you have Tylenol, the acetaminophen. Now, for many, many years, we talked about how safe Tylenol was when compared to the NSAIDs. The NSAIDs are pretty dangerous in and of themselves. Non-steroidal anti-inflammatory drugs are one of the few drugs that's directly absorbed through the mucosa of the gut, through the stomach. And when it does that, it can thin the stomach mucosa, and it can greatly increase risk for GI distress, perforation, bleeding, major GI complications. Additionally, it thins the blood, which is something that's looked for in people that take daily aspirin therapy as it pertains to prevention of heart disease. But for many people who take a lot of these NSAIDs and don't realize it and start mixing it, a few aspirin, a few Advil, a few Aleve, they wind up thinning their blood to such an extent that they bruise easily, and they can actually greatly increase the risk for hemorrhagic stroke or other hemorrhages through the body. Then we look at acetaminophen, which for many years was considered so much safer than NSAIDs, and that's Tylenol. But the fact is that acetaminophen is highly toxic to the liver, and it needs to be taken as directed. Most people will take it as directed, but then they feel that they might need some more, they might need a little extra. The safety profile has been touted for so long that they believe that a little more is not going to hurt them. And in fact, Tylenol overdose is the single most common reason for calls to poison control centers in the United States. It causes disulfide linking in the liver, and is fatal especially in children. In fact, you have to rush a child to the emergency room should they overdose on Tylenol, and they need to be treated with Mucomyst, which in effect is N-acetylcysteine, a powerful antioxidant, to try and stop that liver damage. The other problem is that a lot of people who take stage 2 drugs, and I'll talk about those in a minute, many of those stage 2 drugs also contain acetaminophen. They're combination drugs, things like Percocet and Vicodin. And when you take those drugs, and they're not doing the trick. You take a little bit of Percocet or Vicodin, you're feeling pretty good, but you still got a little bit of pain. You don't think twice about saying, well, I'll just add a Tylenol. I'll take an extra Tylenol. And because you don't know that you've already received a huge dose of acetaminophen, that extra could be enough to cause toxicity. And so you need to be aware of that. So all these OTC drugs certainly are not strong enough to deal with stage 2 or stage 3 pain. But also have a lot of side effects to consider, especially at high doses. Now, if we look at stage 2 drugs, these are only prescription. Okay, once you get to stage 2 drugs, there are no over-the-counter drugs for stage 2 pain. and they include things like Tylenol 3, Percocet, Vicodin, Tramadol, and then also antidepressants are used in stage 3 and stage 2 cases. Now, of course, as I said before, many already contain acetaminophen, and that greatly increases risk for liver damage, especially if you're topping it off with a little extra Tylenol. These also have opiate side effects. They do cause dependency. They can be very expensive. They all require a prescription. And then we have something called the ceiling effect, which means that as you take it, your body grows resistant to the drug, requiring you to escalate your doses to the point where eventually it's just not going to work for you anymore, and you're going to have to go to a stage 3 drug. Even though you're technically in stage 2 pain, these drugs are not going to work for you anymore because you grow resistant to them over time. Now, if we look at stage 3, this is for severe pain. This is where we talk about injectables like morphine. We have hydromorphone, methadone, fentanyl, oxycodone. All of these are highly addictive. They all require a prescription, again, very expensive. All of these over time cause liver and organ damage, and again, they require escalating doses for use. I would say that probably the biggest issue is, as you said before, Dr. Abajabi, the biggest issue is that people become addicted to them. And when they become addicted, whether they're in pain or not, they need to continue taking the drug. And so it blocks up the system with people consistently needing prescriptions for these drugs when, in fact, they might not even be necessary anymore. So we really need some sort of replacement for the stage 2 and the stage 3 drugs. Now, this is where a new option comes in, and we introduce Cobroxin for chronic pain. And I'll explain exactly how this works, but it is an over-the-counter pain drug. It'll be available in stores probably by end of October, beginning of November. But it does actually function as a product for moderate or even moderate to severe pain, leading all the way up to 7, just shy of severe pain. It is, in this case, as you see in the slide, it is an OTC. So it really completely abrogates the need for a prescription. And it does range all the way from a 1 to a 7 in the pain scale when used effectively. So what is Cobroxin exactly? It's as I said, the only OTC pain category 2 painkiller. It is non-opiate, it is non-narcotic, it is non-addictive, it's been clinically proven, and it's safe. And in the last trial we conducted, we matched it against morphine. It was clinically proven to be superior to morphine. And in fact, the doses are so low. These are peptides, small proteins, and the doses necessary for function are so incredibly low that when matched against morphine on a molecular basis, it's actually 600 times more potent than morphine. It's unbelievable because these are peptides and they're very specific.
Rick, if I didn't know you better, I would have said you were lying. This is just doesn't seem to be possible to me because.
Well, that study was published a few months ago. We did announce it on our website, and reprints are available. Probably on Cobroxin.com you can get some copies of these. But as I said, when you use these narcotics, you tend to use very large doses, and with peptides, very small doses are highly effective. So when we talk about where Cobroxin fits, and we look at the different pain markets, things like period ovarian pain, menstrual pain, migraine, sore throat, nerve pain, and there's a picture of shingles, which anyone who's ever suffered from shingles, it's horrible. Lower back pain, as we talked before, head and neck pain, and arthritis, including rheumatoid arthritis. And there we see a picture of someone with rheumatoid nodules. All these we have a clinical indication for treating all of the pain associated with these conditions. Understand that $6 billion is spent on over-the-counter painkillers on an annual basis and $14 billion on RX. And here we have a crossover. We have a product that actually functions a lot like a prescription drug, but is going to be available as an OTC. So it really creates a new category by not requiring a prescription.
Would this include pain from spasms like gallbladder, kidney stones, things like that?
Yeah, absolutely. They still follow the same neurologic pathway. So yes, it could greatly reduce acute pain as well, although our primary concern, our primary indication is going to be for chronic or persistent pain.
Okay.
Now, the main ingredient, or actually the only ingredient in Cobroxin, is actually cobra venom. It's when cobra creates this venom, it is a family of different peptides, small proteins, and the different proteins bind to different neuroreceptors in the body. For over 100 years, cobra venom has been used to control severe pain, even in China and even in the United States. It was considered the top-tier painkiller. In fact, right up until the 1940s, even through World War I and beginning of World War II, medics still had cobra venom as a choice for dealing with post-operative pain and severe pain, especially cancer pain. And it wasn't until things like cortisone came about and morphine became much more available that cobra venom fell out of favor. So there have been numerous clinical trials completed. It has an incredible safety profile. It controls a broad range of different pain, and the emphasis in the clinical research, as I said before, was on cancer pain and arthritis, especially rheumatoid arthritis. Now, Receptipharm is a wholly owned subsidiary of Nutripharma. They did the research in this, and they sought to identify the active components and try to figure out exactly how this cobra venom worked to be able to bring this product to market. But let's look at some of the clinical research that was conducted. This is research that was conducted over the last 100 years, and we can see benefit rates as high as 98% in clinical studies, which is amazing.
Wow.
And even at 60%, it's pretty impressive.
Yes.
But then again, there were problems with some of these cobra venom dilutions and cobra venom formulations. Even some of the dosing protocol might have been flawed, and we've corrected all these problems. Look at some of the side effects, and this is something interesting. I already told you before there's little or no side effects reported, and there really isn't. When we look at these trials, any of the trials where it says none reported, these were trials where the patients were, in essence, virgin patients, where they weren't on other medications. The problem with some of these other patients is they were coming off of morphine and other drugs, and some of the side effects reported in these are really their withdrawal side effects, being withdrawn from the other drug and starting to use the cobroxin. And so there is some overlay with this. The biggest side effect we see is people that take high doses tend to have a dry mouth and dry throat, and then diplopia is the most dangerous side effect that we've reported in our studies, which is double vision. Mm-hmm. And I love that as a side effect. If you take so much of this drug that you start to experience double vision, it tells you you've taken too much. And it's not dangerous at all, and when your vision clears, you can take more. So it's a non-dangerous, great little side effect, and I'm talking incredibly high doses. We've given people what it could be the equivalent of a 3-year dose before we've seen things like diplopia. Okay? So it's incredibly safe. In fact, we are marketing the product in a 1-month supply bottle, and one of the things we say is if your child got into that bottle and drank the whole bottle, the worst thing that would happen is you'd have to buy another bottle. Huh. It's just not dangerous.
Wow.
Now, if we look at some of the other studies, what I love about this is look at the amounts. We're talking about doses of micrograms, 4 to 10 micrograms, 10 to 20 micrograms, and the applications in these clinical studies. Things like cancer pain were the most studied, migraine headaches, arthritis, post-operative pain, and even type 2 diabetes for neuropathic pain. And so we have all these studies are available on the Cobroxin website, so you can see at least the citation for the study, the abstract. We are trying to get full text articles so everyone, any physicians or pharmacists can do their research, and it will be right in the clinical trial section on the Cobroxin website. Now, you're going to ask yourself, cobra venom, and isn't that a little weird to try and derive drugs from venomous animals? And it's really not the first time it's been done. In fact, neuroactive peptides from venomous animals have been used for years in clinical research and in drugs. In fact, one of the drugs I worked on myself was from cone snail venom. When I was in graduate school, I used to actually dive and collect cone snails from the ocean. And cone snails are venomous snails that exist on the bottom of the ocean, and they stick out their proboscis, which kind of looks like a worm, and it's got a sharp tooth at the end of the proboscis. And when a fish comes to investigate to basically eat the worm, the cone snail will stab the fish, inject the venom, and drag the fish in, the paralyzed fish in, and eat it. And so cone snails are really very interesting. There's over 500 species in the world. And there is a specific species, Conus magus, found in and around Australia, where they derived an omega chronotoxin, and the company Elan Pharmaceuticals has launched their own pain drug from that omega chronotoxin called Prialt. And Prialt was launched about 3 years ago. Now, the difference between Prialt and Cobraxin is, first of all, Prialt is an ethical drug that went through clinical studies, specifically because it needs to be injected intrathecally. They actually inject it directly into the spine, and they replace morphine and pain pumps with the Prialt. It does have its side effects. It does have its own issues because it has a different mechanism than we have with the Cobraxin. And then we have other things like bee venom is malignin that's been used in MS patients. Cobra venom, which is what I'm going to talk about, specifically alpha cobratoxin, which is one peptide from cobra venom. Rattlesnake venom is crotamine, and that's been used as a potent blood thinner. In fact, Millennium Pharmaceuticals has a drug from rattlesnake venom. Scorpion venom is calliotoxin, morotoxin, which has been used in clinical studies. Then we have robustotoxin and atritoxin from the funnel web spider found in Australia. Human toxin from the South American tarantula. Alpha-latrotoxin from the black widow. And then another drug that's actually on the market is Byetta. Byetta is the peptide, the small molecular entity called Exendin-4. And the original name of the drug was exanatide, but that's from the Gila monster venom. Someone figured out that when a Gila monster bites you and you pass out, one of the reasons you pass out is you have a precipitous drop in blood sugar. You become extremely hypoglycemic. And he thought, well, maybe that would be good for diabetics. And so they started studying that compound, and they launched, the Amylin Pharmaceuticals launched the drug Byetta a few years ago, and it's basically an insulin sensitizer that's used by many diabetics today.
Quick question.
Sure.
Okay, I understand the last one, because while you were going through all those venoms and those toxins, I was thinking, what would make anyone go study these toxins in the first place? I mean, why would they study them? Okay, I understand with the Gia monster, but how about the rest? I mean, why do people study the toxins in the first place?
Well, it's much the same reason why if someone might eat a poisonous berry, and we study the poisons from that, and we actually derive therapeutics from those. The fact is, if something has a physiologic response, if something actually affects the body, then there's a chance that taking that and altering in some way will actually provide some sort of therapeutic benefit. Is there any doubt that when a cobra bites you, there's a physiologic response?
No.
Absolutely not. And one of the funny things we talk about is we're expanding our studies into veterinary products to use our venom components in dogs and cats, companion animals. One of our drugs is actually for the treatment of feline leukemia. And when people say, well, how do you know these work in animals? Our answer is always, well, a cobra, when it bites you, doesn't care if you have 2 legs or 4. It's still going to work. And so the fact is, you look at these peptides and how they affect vertebrates, especially humans, and you find that single peptides are, in fact, not toxic, but can be therapeutic. And even whole venom components can be non-toxic at very low doses, even though they can be toxic at incredibly high doses. Additionally, we modify some of our products at Nutripharma where we denature the toxins so they're completely non-toxic, but they still have therapeutic benefit. So you really get into these things and get into this sort of research because the understanding is if they have some sort of physiologic effect, they could possibly become therapeutic.
Got it.
So the mechanism of action, we understand some of the mechanism of action of the Cobraxin in that we understand some of the peptides that are in the cobra venom. The primary effect is that it binds to the nicotinic acetylcholine receptor, and I'll explain that in a few minutes. But because these are peptides, they don't clear through the liver, so they don't cause any liver damage. The product has no effect on cardiac tissue. It doesn't bind to those muscles. And in all studies in cell culture and teratogenetic studies, which are cancer-causing studies, it's been found to be completely non-toxic in cell culture, and it's non-teratogenic. It does not cause cancer in any cell line. And it's very specific for the receptors it binds to. And let me just explain that for a minute. Most drugs are what we call small molecular entities. They're small molecules that bind to a bunch of different things. And depending on what it binds to, it can cause side effects. So if you bind, and I'll take statin drugs as an example, Lipitor, Mevacor, Zocor, Prevacol. These drugs bind to an enzyme called HMG-CoA reductase. And when they bind to that enzyme, they can stop the production of cholesterol. That's one of the functions. But they also bind to an enzyme that produces mevalonic acid, which is necessary for muscle function. And so that's why in many cases, when you're on a statin drug, you can have muscle damage or muscle pain due to that breakdown of the enzyme that normally produces mevalonic acid. So the less specific a drug is, the more side effects it will have. Now, the wonder of biologics, and especially peptides, is they're very specific. They have a specific shape. It's almost like the difference between a master key and a regular key. You know, it's like a three-dimensional key that has to be the perfect shape and the perfect size to be able to do its job. And so these peptides are so incredibly specific that they have very few, if any, side effects. And so that's why I threw myself into peptide research even when I was an undergraduate in college, because I liked the concept of few or no side effects from therapeutic agents. So let me try and simply explain what the acetylcholine receptor is. First, understand that for the most part, your nerves don't touch. Neurons don't touch each other. There's a gap between them called a synapse. And for a charge to go from one nerve to the next nerve, the presynaptic nerve releases neurotransmitters. It'll release some sort of chemical that crosses the synapse, goes from one nerve to the next, and attaches to receptors on the postsynaptic nerve. Once it attaches to those receptors, it opens up a channel and allows ions, usually calcium, sometimes sodium, to go from one nerve to the other. It's almost like an electric charge going through the nerve. And to hop from one wire to the next wire, that little spark, it has to have a little help, which is the neurotransmitter. And I'll go a little deeper into this for people that aren't biochemists on the phone. Here's a nice little example. And you can see on the left is the presynaptic nerve, and it's shooting out acetylcholine, which is a neurotransmitter. The green spots on the postsynaptic nerve are acetylcholine receptors. The acetylcholine will go across and bind to those receptors and open up channels in the nerve that allow for ions, like calcium, to get in and cause the wave of depolarization, basically carry a signal. Again, I'll show this is an acetylcholine receptor sitting in the nerve membrane, in the neural membrane, and the two stars at the top are actually an example of the spots where acetylcholine will bind. Acetylcholine is a neurotransmitter. It's very potent, and it fits right on those spots that tell the nerve to work, that tell that receptor to open up. Let me show you exactly what that looks like. What happens is very interesting. The acetylcholine receptor has 5 subunits. They look like tubes, and they sit right next to each other. And the tubes have little side chains that stick into the middle of the channel and block the channel. So you can see the top picture on the right, the channel is blocked. But when acetylcholine binds to the receptors on the outside of the nerve, all those tubes turn. And like the iris of a camera, it opens up the channel so ions can fit through. So it simply opens the channel and closes the channel. Okay, so that's how these acetylcholine receptors work. Now, one of the mechanisms of the alpha-copratoxin, which is a component of the cobroxin, is that it blocks that acetylcholine receptor. Now, it doesn't block it well. It blocks it actually not very well at all. But it's enough to actually modify neurotransmission. So especially when we talk about pain traveling through the nerves, it modifies that transmission of pain. So anywhere that there's a lot of activity, it's going to slow that activity. And so the nerve channel by which pain travels is in effect shut off. So you can still function, you can still do everything you normally do, but the nerve no longer carries that pain signal because the channel itself has been blocked by the drug. Now,
that's specific.
Do you have a question, Dr. Abijad?
Yes, sir. That's very specific. It works only with the acetylcholine receptors. Is that what you're saying, or does it work on other?
Actually, it's even more specific than that because there's many subtypes of the acetylcholine receptor. It only works in the alpha-7 subtype of the acetylcholine receptor, which is very specific on very specific channels in the central nervous system and also on the nerves, and this on the immune system cells. And that's another interesting fact about this drug. I don't have slides on this, but I'll explain it. The alpha-7 subunit of the acetylcholine receptor exists also on white blood cells and immune system cells. And when the drug, the peptides, attract to those receptors through a series of signals, it actually turns off the inflammatory process. And so we found that this drug is not only a painkiller, it's also a potent anti-inflammatory. So it's very fascinating. Now, we do claim anti-inflammation as well as pain, but some other things we're studying is its antipyretic effect. It seems to also work in lowering fever. Certainly not as well as some of the NSAIDs, but it's something we're looking into, especially with things like swine flu approaching and some other issues out there. We'd like to know exactly what its effects are, not just on pain and inflammation, but also some other body functions.
Right. Wow. Okay.
Now, how are we positioning this for the market? Understand that there's a lot of people there that might be happy with their Aleve every day or their Advil every day, but there's a lot of people out there that can take those products, that might have side effects from those products. But there's also people that really can't get the prescriptions when they need their stage 2 or stage 3 drugs. They don't have health care insurance. It's 42 million Americans. And a lot of these people, even with insurance coverage, don't have prescription coverage. Then a lot of people are afraid of opiate side effects. Now, I'll tell you this, I don't like to take opiates. I hate to be in pain, but by the same token, I don't like to be drugged out. I don't like to feel like I can't concentrate. And so I will never, even in surgery, won't use opiates. And now, of course, I don't need to because I have access to something like Cobraxin. There's a lot of people that are afraid of the opiate side effects. There's people that are subject to drug screening at work, and even with the prescription and the understanding that you're taking these drugs for a reason, it can still cost people their jobs. And then, of course, there's people that have used NSAIDs forever, and they just don't work anymore. They were overdosing on aspirin or Advil or Aleve, and it was eating away at their stomach, and they just can't take it anymore. They can't go and get a prescription, and so they just live with the pain, especially chronic back pain. And then lastly, as I was saying before, doctors now are just downright afraid to prescribe pain drugs, these opiates, because they're getting investigated left and right. I mean, look what just happened with Michael Jackson, with his physician. Of course, he went far beyond what most doctors do. But the point is, here's a patient, a wealthy patient that wanted these pain drugs, and he had the wherewithal to afford them, and the doctors wrote those prescriptions. And as I said earlier, pain clinics and pain centers are being shut down across the country because they're being considered simply prescription mills, places where addicts can go and just get their pain prescriptions. And so doctors are afraid to be thought of as a drug pusher, simply prescribing opiates, so they don't want to. So this really allows them to offer something else, to say, here's an over-the-counter pain drug, Cobraxin. Why don't you try that first and before we try anything else, okay? And also, besides NSAIDs, besides the over-the-counter product, there's a lot of consumers out there that are just now not well served by things like Percocet and Vicodin, and the FDA has now issued a very stern warning with any products that contain acetaminophen. They get a black box warning on them that says, warning, these products contain acetaminophen and cannot be taken together, and in fact, acetaminophen, Tylenol, can cause severe liver damage. And so there's a loss of availability of those products. They're not as available as they used to be. Now, we do have 2 products that we've launched that will be coming out end of October, beginning of November. There's an oral spray, which is the main product. It's 1 ounce in volume, considered to be about a 30-day supply. And then we have a 2-ounce topical gel. Understand the difference. The oral spray is systemic. It's especially for head and neck pain and lower back pain, deep tissue especially, and it's something you're going to use every day. Because this is a peptide, you need to grow sensitive to it. And so when you first take it, it can take up to 2 hours when you first start using it to really see a maximum effect. And it can take up to 2 days to build in your body, especially in chronic pain. Now, I'm not saying you won't feel an effect right away. There's people that have acute pain that take it and they can't believe how fast it's effective for them. But for the most part, if you have chronic back pain, chronic head or neck pain, it can take up to 2 days to maximize the effect of the product. So you need to continually take it. Additionally, because it's a peptide and the body starts to grow used to these peptides binding to those receptors, you actually grow more sensitive to it over time instead of resistant like other drugs. And so over time, you actually need less and less of the product to get the same benefit, which is amazing, and it's probably one of the biggest failings of us as a company is eventually everyone will need very little of the drug as they use it, you know. But it's really fantastic because if you're ever worried about side effects, you use less and less over time to really get the same benefits. Now with the topical is really meant for thinner skin, especially in arthritis, your hands, your feet, your knees, your elbows. The topical is really not recommended for neck pain or back pain because those peptides, it's just too hard for those peptides to get through that much tissue. So we would recommend that even with people that have things like rheumatoid arthritis, they would use the oral product to get systemic benefit, and then if they still have a little pain in their hands, they can use the topical as well. I'd just like everyone to know that the product is marketed exclusively in the U.S. by the company Zenicare Holdings, and you can get more information on that online.
So
Now,
Canada's out.
Canada, we're not registered anywhere except the U.S. at this point. It is registered as a homeopathic, which is a homeopathic pharmacopoeia of the United States, and there are different rules in different countries depending on the availability, and there are rules as to homeopathics or ethical drugs. We are looking at Canada, we're looking at Europe, we're looking at Australia, a variety of different countries to move this product in, but at this point we're only marketing in the United States. Now, everything I've talked about so far is at stage 1 and stage 2, but we also have stage 3 to consider. What about people in severe pain that right now, cancer pain, they're in morphine or drugs of that nature? We really need an alternative. Those pharmaceutical products are narcotic-based, they're addictive, as I said before, they induce a tolerance, and they wear off quickly. Biologics, like peptides that have been used before, tend to be difficult to administer. Many of them are injectable, can have significant side effects, and they have stability issues. A lot of these peptides are very unstable. They need to be refrigerated, they need to be handled carefully, and they usually are refrigerated as a powder, which then needs to be resuspended. So there's a lot of issues with those biologics. And we don't have any of those issues with our cobra venom formulations. So we really need an alternative to those opiates and even those biologics. And so we are expanding our marketplace. Aside from the Cobroxin, we will be launching a prescription version of the Cobroxin. It's going to be called Niloxin RX, and we expect it to be out sometime early next year. And if you look at that market, the stage 3 market, look at oxycodone alone. It's almost $3 billion in sales. Morphine, $965 million. Fentanyl reached sales of $1.5 billion. And the Niloxin RX, the prescription product, really should be able to replace any of those drugs when it's available. So we are doing some clinical studies, we're doing some more research, but we do expect that to be available sometime early next year. Just to finish up, anybody, if they have any questions, most of the information I've shared with you today is on the website, cobroxin.com. There's lots of great information there, and there's places for you to leave your comments. Again, if the question is when is it going to be available, the product is being marketed now, but it's not going to be available until the end of October, beginning of November, and in many stores it won't be available until January when it's going to launch nationally. Cobroxin is a NutraPharma product, so if anyone has interest in looking into our company, we're at NutraPharma.com. We're a publicly traded company on the over-the-counter bulletin board, trading under the symbol NPHC. David, thank you very much for everything. Do you have any questions?
Oh, absolutely. Absolutely. Thank you very much, Rick. This is a record. You usually go for 2.5 hours at a stretch.
I usually have my whole book to talk about.
Oh, great. Well, first of all, I mean, when I was thinking, when you were just bringing out those amazing statistics and results, research results, I was like, this is going to turn the whole pain industry on its head. I mean, are you sure you're going to be able to handle the backlash that comes from this? Because this is.
I don't think we'll have backlash. I mean, in fact, like I said, cobra venom was used historically, and anybody looking into the history of this is going to see, yeah, that makes perfect sense. Now, of course, there's always going to be some people that are the naysayers, but the clinicals bear us out. And that's another reason that we launched this as an over-the-counter instead of launching the prescription version first, because as an over-the-counter, it becomes the consumer's choice to try the product. And so consumers are already going to try the product, and believe me, we've had literally hundreds of people, friends, family, company affiliates, use the product with just an amazing amount of success. And so we understand that the product absolutely works, and as the consumers start to build a market for this, really a demand for this, they're going to be going to their physicians and saying, have you heard about this? And we are putting together medical courses for physicians and pharmacists so they can better understand the drug itself and be able to answer those questions. But we believe that sometime in the next 12 to 18 months, this will be a drug of choice for pharmacists as a recommendation for an OTC pain medication.
Oh, and it's just amazing what you said about it accumulating. I was thinking about it accumulating in the body, and you're saying that that's even to your advantage that it accumulates in the body, as opposed because you eat less and less.
Don't get me wrong; it doesn't accumulate in the body. Peptides are very easily broken down. Enzymes break down proteins in the body all the time. Even if you get bitten by a cobra, if you can keep your heart beating, your lungs breathing, your body will dissolve or destroy those peptides pretty quickly. And so it doesn't store in the body, but what happens is your receptors become sensitive to the drug. It's called induced fit. Basically, the more the drug binds to the different receptors, the more receptors are used to it. And so you grow more and more sensitive to the drug over time. So we do say on the packaging it needs to build up in your body, but that's kind of a misnomer. It doesn't really build up, but you do grow incredibly more sensitive to it, even in a short period of time.
That's against everything we've been taught in medical school. Really?
Well, not with peptides. I mean, if you look at somebody that even look at somebody that's been bitten by a snake. The first time they're bitten by a snake, they might survive. The second time, they're actually much more sensitive to those venoms, and it usually is fatal.
Okay. Got it. Got it.
And any kind of neurotoxin works the same way. People that might have neurotoxic herbals, the second time, third time they actually use those herbals, it can actually kill them. And look at rapid detox. When they do rapid detox of things like heroin abuse or morphine abuse, if they, in fact, use morphine or heroin after the rapid detox, that could be a fatal dose because their bodies are so sensitive now to the drug. So this isn't exactly a new mechanism, but it's fascinating because it's the first time a pain drug induced sensitivity.
Right. That's the point. Wow, this is huge. Okay. David, if you're on the line, I'm going to be sending you some questions as well. The things I think you'll be able to handle. And by the way, David Isserman, who's your, what's David's role in this whole thing? Rick.
David Isserman runs a company called Isserman Consulting. He's a consultant to Nutripharma. He basically oversees our investor relations, our websites, our PR, and basically the public side of Nutripharma is handled by David Isserman. He does a fantastic job.
Okay, great. I'll be David. Check your chat box. Questions related to public relations and investments. I'll send some of those over to you as well. Also, he asked if we could provide the recording of this webinar on the Nutripharma's website. We will do so. So if you ever want to review this webinar, you want your friends to go there, you can see it on their website. It's going to be on our website as well. Obviously, there's a fee attached to ours, so I guess you have a better choice to go to their website and watch this thing again. All right, I am a chronic patient. I'm on 2 long-acting oxycodone per day and 30 milligrams per day of oxycodone. Will Cobroxin actually be able to take the place of the oxycodone? I have 2 spinal cord implants for chronic pain as well.
Well, understand this. Her issue is traumatic. Okay. So she has real pain caused by physical trauma. Now, the Cobroxin certainly is going to have the same pain-killing effects without the opioid side effects of things like the oxycodone. And so we would expect over time, as she uses the Cobroxin, to be able to reduce or eliminate her need for those other drugs. But one thing I'd like to point out is that this is not a cure or a cure for your pain. This is not a cure for the underlying syndrome. It's not going to fix her back. It's simply going to relieve the pain. And something that I'd like to point out is that pain is actually a good thing. A low level of pain tells you that something is wrong. And so it's really important that not all the pain goes away. So, in fact, people who have severe pain really should be on what will be our prescription drug, which I said will be coming out next year. but you can use additional cobroxin at this point to certainly take the edge off. But like I said, you really want to feel a little bit of pain so you don't do something that might be dangerous. I'll give you a great example. I went to high school with a kid that had sprained his ankle, and he took Percocet at the time. And when we went to a dance, and he wanted to impress these girls, and he's dancing. I said, you know, you sprained your ankle, it's swollen up, you have all these problems. He goes, oh, it feels fine, it feels fine. And he danced all night on it. And I got to tell you, by the next morning, he couldn't stop crying. There was no amount of pain drug that he could take that would help him. His foot was swollen up like a football. And the fact is, he needed to feel a little bit of pain so he would take it easy on that foot, not cause further damage.
Right.
So you always have to be careful of traumatic pain, and so I would surmise that she'd be able to certainly reduce, if not eliminate, those other drugs on the cobroxin, but she should also be concerned about what she can do about healing her issue.
Makes sense. Makes sense. I hope that guy eventually got the lady, though. He was dancing with. Okay.
Oh, yeah.
Okay. All right. On the website, it shows it is in phase 1, but as I followed the NPHC last update, it was going into phase 3. What phase is it in now?
Okay, we didn't approve it as an ethical drug, and I'll try to explain the difference. Ethical drug approval is when you actually take a drug and you go through phase 1, phase 2, and phase 3 clinical studies, where phase 1, for the most part, are safety studies. Phase 2 is preliminary efficacy in humans, and phase 3 are the larger trials to look at side effects and dosing and things of that nature. After that, you take all the clinical information, you give it to the FDA, and you fill out an NDA, a new drug application, where the FDA can evaluate it and decide if it can be launched as an ethical drug. We were in that process with the cobroxin. We are in that process with venom components, which include RPI-78M for multiple sclerosis, RPI-MN as an antiviral medication for HIV. So we are in that process with other drugs. What happened is we started looking at the doses that we were giving out. These doses are incredibly small. You're talking 4 to 5 micrograms per spray of the cobroxin, of the venom peptides. Well, there is a concept in the United States called homeopathic. Homeopathic drugs are basically something that might cause dysfunction at high doses, but get diluted over and over and over again to where a lower concentration of the drug or the components is actually therapeutic. And since 1938 in the United States, homeopathic drugs are considered to be safe, effective drugs. And you can have a drug registered as homeopathic provided it appears in the Homeopathic Pharmacopoeia of the United States, and there's clinical evidence to support your claim. And so while we were consulting with the FDA, we hired a homeopathic FDA consultant, and he told us that because our components are so small, our amounts are so small, we actually qualify as homeopathic. So it completely abrogated the need for us to go through the phase 1, phase 2, and phase 3 clinical studies for the ethical drug. Now, we've already done safety studies. There's already been over 100 published studies in the use of cobra venom over the last 100 years. So we understand how it works. We understand exactly what this drug does, and we understand the dosing. Understand, unlike most other homeopathics, there are compounds in there. The compounds have physiologic effect and physiologic action. It's just that the compounds are such a small concentration that it qualified for very quick approval. Now, understand we are going to do a few more clinical studies to support the prescription product, but those are not even necessary. Those studies are being conducted simply to provide information for doctors and pharmacists in the use of the product.
Great. Has cobroxin been compared to the pain relief experienced with capsaicin? Is that how to pronounce it? Capsaicin?
Yeah, capsaicin. Capsaicin is a compound. It's from the chili pepper. It actually turns on certain different neurons and overwhelms those neurons. So it's used mostly in topical pain. I've never seen capsaicin used internally, let's strike that. I've never seen it used successfully internally for systemic pain. Capsaicin usually supplies a topical along with other ingredients like menthol and lidocaine and things like creams and rubs for the surface. And much like those other products, there's a burning sensation or a cooling sensation when you use them. You don't have any of those things with the Cobroxin. There's no menthol, there's no camphor, there's no lidocaine in the Cobroxin topical product because it really functions the same way that the oral product does. It's peptides that attach directly to the nerves. I would hazard to say that the Cobroxin is infinitely more effective than capsaicin as a painkiller. Now, capsaicin has other uses. For example, it's used nasally for migraine headaches, and that seems to be highly functional, although there are side effects associated with that, including burning the nasal passages. And we haven't done those clinical studies in direct comparison. But again, I would hazard a guess that the Cobroxin is certainly has fewer side effects and is probably more potent. David, did I lose you?
Guys, I muted myself. Okay. Will this will this replace the intractable pain that has to have opiates? I guess you covered this, but will this replace the? Yeah, you did that. Okay. Is Cobroxin a good substitute for Bextra?
For
Bextra.
Well, Bextra. Yeah, Bextra is just a COX-2 inhibitor. I mean, it's just like Vioxx and Celebrex. It's in fact just kind of potent aspirin, and has all the same side effects as other NSAIDs, GI distress and the like. COX-2 inhibitors have also shown to increase risk for heart attack and stroke. So I would certainly say it'll give better benefits than Bextra, even as an anti-inflammatory, without the side effects associated.
That's good. Someone is trying to be sure you said it right. Do you mean 600 times greater pain relief than morphine?
On a molecular basis. That's important to understand. I'm not saying that it works 600 times better than morphine. The fact is we're using incredibly small doses, 4 micrograms, as opposed to 300 to 400 milligrams of morphine at a dose. So on a molecular basis, molecule by molecule, it's 600 times more potent. Now, it does take longer to affect than morphine. In fact, in the published study, we showed that just looking at the rat brain, the parafascicular nucleus, the rat brain, where pain is processed, the morphine kicked in something like 10 to 20 minutes, whereas it took as much as 40 minutes for the Cobroxin to kick in. The Cobroxin lasted 4 times as long as the morphine, so it was a much longer effect, and it was a greater effect than the morphine. So you can really say it's at least 4 times stronger than the morphine in that effect, but at a molecular basis, on a molecule-by-molecule basis, it's 600 times more potent.
Okay. What is the shelf life?
It's really infinite. They're technically denatured proteins in solution. They're bottled in a sterile environment. We do put dating on it. Well, we have put dating on it of a year. But we do recommend that people use it. They don't let it sit around. And we'd like them to use it after opening or after first using the product, especially the topical, to use it within 90 days.
All right, here's a question investment-wise. I've sent some to David. I think he's still trying to figure out how the system works. But let me ask you this. Where do you see this product going, and how is it going to affect the stock? I would think this product should become the drug of choice. I would think so, too.
Yeah, I would think so, too, but you never know in this marketplace. I would expect this to be highly successful. As I told you before, the combined OTC drug market is certainly more than $20 billion a year. I would like to get a little percentage of that.
That would be nice. Yes, it would be.
I can never hazard a guess as to what the stock price is going to do, but understand that most biotech companies at our stage of development don't have any revenues at all. And we do expect to have some significant revenues over the next 12 to 18 months, which certainly should affect the stock price.
Got it. Okay, so let's talk about supply. I know some people are asking, is it going to be in Walgreens? Which pharmacies is it going to be at? Which drugstores are you projecting will handle this product?
Yeah, at this point, we really can't say. We did attend a meeting called ECRM, which was a buyers conference, and it was really fantastic. There were over 1,000 people there, and there were buyers from all the major chains. There was Target and Kmart and Walmart and Walgreens and Rite Aid, Kroger's, Publix, and even the catalogs like Dr. Leonard's and things of that nature. And then even the wholesalers like McKesson and Cardinal Health and Amerisource, they all attended this meeting at ECRM, and with approximately 60 products being launched at that meeting or being promoted at that meeting, the Cobroxin was voted best product in show. So the buyers themselves from all the different stores vote on this, and so they saw us as a really a game-changing product. So my guess is we'll see it in all these stores eventually, but it'll come out over the next several months in the smaller stores, and then, as I said before, as we start doing television advertising in January and February, you're going to start seeing it in things like Walgreens and Rite Aid and the larger chains.
Sales forecast.
I can't even begin to tell you. You know, we'd like to think that we're going to do at least several 100,000 units a month over the next 6 to 12 months. We have forecast to do between 1 and 1.5 million units a month over the next 12 to 14 months, just to make sure that we had enough supply and to scale up from there. But again, performers are really fairy tales. You never know what's going to happen. We'll know more over the next 3 months as the product hits the shelves and people get to experience it.
Are you going to have pharmaceutical reps, well, I don't want to say attacking, but barging in on doctors' offices to talk about this?
Well, not yet, not for the OTC. That's just not necessary.
Oh, yeah, that's
we have
right.
brokers in the stores. But come next year with the prescription product, after we complete our clinicals that we are going to conduct, yes, there'll be pharmaceutical reps all over the country giving information to physicians. As I said before, we're putting together continuing education courses for physicians, nurses, and pharmacists and chiropractors so they can better understand the drug and how it might be useful in their patient population.
Well, let us know what we can do to help. This is good stuff. These are more acute questions. Does it help with snake bites or insect bites?
That's a really good question. Snake bites, I mean, certainly it's going to help with the pain, but it's not going to do anything about the envenomation. I mean, that needs to be handled through anti-venom or however else, locally your poison control board will take care of it. And then insect bites as well. I mean, topically, I would guess that certainly it'll take away the pain and the itch. It is anti-inflammatory, and it should help a lot.
Can the NCDs work on the toxins from these bites?
I'm sorry, oh, the NCD, the zeolite?
Yeah, the zeolite.
Yeah, most people on the call don't even know what that is. So,
okay.
But yes, the Natural Cellular Defense is a great product for things like insect bites simply because it helps stabilize the pH of the region, and a lot of the pain and itchiness that comes from insect bites are pH issues.
Okay, great. Does Cobroxin have any effect on GSH levels in the liver?
No, like I said, it has no effect whatsoever on liver issues. It's not going to raise or lower liver enzymes because it's not metabolized through the liver, being peptides and not anything like small molecular entity drugs. And so we really don't believe it's going to have any effect on the liver unless, in fact, the liver is damaged for some reason, and as the peptide works as an anti-inflammatory, it might, in fact, help the liver.
Great. For someone who suffers from periodic migraines and cannot plan before the migraine episode, would they take Cobroxin proactively on a daily basis since it may be hours before the Cobroxin takes effect? Can you be using it on a regular basis? Is there any danger in that?
Yeah, in fact, that's its primary use is for persistent or chronic pain. I'd certainly recommend that someone who's migraineur that suffers, 2 or 3 migraines a month would probably want to take this on a daily basis and take it as a preventive instead of just a treatment.
Is there a good time to take it? Morning, afternoon, evening?
Anytime. Like I said, there's an overlap for use, and so we do recommend taking it 2 to 4 times daily. But I know some people, the longest time you're going to go without it is going to be during your sleep.
Right.
So we do recommend people take it just before bed. And what you're going to find out is that normal creakiness, that normal pain you feel when you first get up is just not there if you take it before bedtime.
Great. Does it help fibromyalgia?
We don't have any claims specifically to the syndrome of fibromyalgia, but we have anecdotal reports from people who've tried it, who have fibromyalgia, and they've said it's a remarkable product. So they said certainly the pain and sensitivity related to fibromyalgia is greatly reduced with the product.
All right, for those of you asking questions about marketing and all that, yes, David Eastman answered this. There's a marketing campaign being organized by XenaCare. XenaCare announced its first phase, which are magazine ads in November that include Arthritis Today, Prevention, Health, Star, Woman's World, Soap Opera, and Self magazines. It is also working on the TV commercials and online marketing, and Rick mentioned that as well. Okay. Wow, these questions they keep popping in. Okay, someone wasn't clear about what you said about tolerance and that. So here's what he says: if the human body's receptors become sensitized to cobroxin over time, do people develop tolerance to the medication? That is, does one need more medication for same effect, or does one need a drug holiday from time to time?
That's exactly the opposite. As I tried to say, remember I showed you how the acetylcholine receptor works. It's
Right.
like an iris of a camera. When something binds, when acetylcholine binds to that receptor, it'll open or it'll close due to the presence of that compound. What happens when the peptides touch that receptor is something called induced fit. The receptor changes shape slightly to accept the protein, to accept the peptide. And the more times it does that, the easier it is to fit. It's almost like say where you put your key in the lock, and the lock was made of Play-Doh, and it was a little squishy and changed shape. Well, the more times you did that, the more that it was going to keep that shape. And so this induced fit becomes more effective over time. And so you grow more sensitive to the drug instead of resistant to it like you do with other pain medication. And we've already seen this in people that have been on the drug for more than 3 months. When they first were using it, it was 2 or 3 sprays 4 times a day, and now they're down to maybe 1 or 2 sprays once or twice a day. So they need much less product to get the same benefit.
Okay. All right. Are there any published studies of pain relief in humans? It looks like the ones you mentioned were with the rodents and the morphine.
No, I mean, there's plenty of published studies in humans on the use of cobra venom at different dilutions. With cobroxin itself, the studies we've done recently have been animal studies, how we affect the parafascicular nucleus in rats, which is the way pain is processed, and that's the same process in humans as well. We are going to conduct 2 clinical studies in humans over the next several months. I understand pain studies are very short in duration, whereas, for example, our study for multiple sclerosis will be 12 to 18 months. A pain study is only about 12 to 20 days. So pain studies tend to be very short in duration. We will complete a few studies, certainly the first study this year, but should complete at least 2 studies before March of next year.
How is naloxone different from cobroxin in formulation?
It's simply stronger. It's a much higher concentration, and we standardize it to certain peptides for the effect. That's a basic thing. When you talk about prescription strength versus over-the-counter strength, it's very much the same story.
Okay. Do you have any financial projections that you can share with the group?
No, no, I don't. I'm certainly glad that even now we're paying our own bills. If people have been following NutraPharma, I've been pretty much paying the bills for the last 3 years, and it's fantastic that now we are in revenue. And as I said before, most biotech companies at our stage of development don't produce revenues. So just the fact that we're producing revenues and being a responsible company, paying our own bills, actually functioning as a going concern, means a lot in this industry. And the revenues from the sale of cobroxin and iloxin will allow us to get our HIV drug to market, our rheumatoid arthritis drug, our multiple sclerosis drug, and our adrenal mononephropathy drug. And once we get those products to market, those are markets approaching $20 to $30 billion.
Oh, that's huge. That's great. Now, how long have you been in existence?
NutraPharma has been around since 2002. We purchased part of Receptipharm back in 2003 and 2004, where we started doing this research with the scientists at Receptipharm, and then we founded Designer Diagnostics in 2006, the other part of the company. We completed the acquisition of Receptipharm in early 2007, and that's really when we just buckled down and got to work. And so it's really only been a few years of this sort of labor, basically a labor of love to get this product out.
Good stuff. Okay. It's a good one. Any contraindications to the use of prescription drugs? Any what's the word now? Cross reactions and.
No, we haven't seen any yet, but that doesn't mean that there might be in the future. Mostly we see additive effects. What we found with the studies in China at Soochow University that Professor Qin conducted, who's a Harvard-trained medical doctor, he found that the effects were additive when used with aspirin, for example. So if you find that the cobroxin is doing great, but it's not doing everything, and imagine you've already come off of Vicodin or oxycodone. If you take even low doses of aspirin, it seems to amplify the effects of the cobroxin. So there is an additive effect.
Oh, really?
But we're trying to quantify that and find out exactly what that means.
Okay. Can you talk about, okay, that's the sensitivity thing, tolerance, that they've covered that. I have chronic lower back pain from scar tissue from surgery and cysts that burst. How should I dose? I don't know if are you comfortable answering that question?
Yeah, I mean, certainly it's something you should discuss with your physician. I would simply recommend the recommended dose of the product, which is 2 to 4 sprays, 2 to 4 times daily. Try and build up in your system for a few days and see how you react to it. Chances are, depending on what medications you're on now, you certainly should be able to lower your current medications.
Folks, David Isman just typed this in. People can get updates about cobroxin if they sign up for e-alerts on the NutraPharma website. So there are lots of places to visit on the NutraPharma website, and it is nutrapharma.com.
Yeah, David, what I didn't share is what this is going to cost, and I think that's kind of vital.
Right.
I didn't put that in my slides. The recommended retail price for the oral product is about $19 for a month's supply. If you think about that, if you're taking Advil daily, that runs you about $18 for a month's supply. And people don't realize that. They say, well, a bottle of Advil is like $7, but that's usually only about a week to 10-day supply.
Mm-hmm.
So it's about $18 for a month's worth of Advil, and God forbid you're on Percocet, that's about $100 for a month's supply. So somewhere around $19 for a product like this is certainly within the ballpark. And then the topical, which is also considered to be a month's supply, is around $20 for a bottle of that.
I think that's a steal. That is minus all the side effects. For goodness gracious, I mean that's.
Well, we wanted to make everything affordable, and even the HIV work we're doing. I mean, we should be able to treat HIV patients for as little as a few dollars a day. And so what we want to do is not just make the drugs available to people, but make them cost effective.
Well, that helps. That helps. Has anyone with reflex sympathetic dystrophy, complex regional pain syndrome, those are two conditions, tried this and been helped?
No, we haven't specifically looked at reflex sympathetic dystrophy, RSD. I am familiar with people that have RSD, so it will be interesting to see. I would expect it to work because it is a form of neuropathic pain. Most people experience RSD post-trauma, say after a car accident or something like that, where after they've experienced pain, their nerves simply don't go back to normal. They simply continue to experience that pain. So that is a form of neuropathic pain. I would expect that they'd be highly benefited from the cobroxin.
Is there any effect on the brain for mental anguish or anxiety? And I probably would add chronic depression as well.
Yeah, that's one of the indications in the homeopathic pharmacopoeia, but we didn't talk about this as an antidepressant. And it's hard to tell because the fact is if you're in less pain, you're not going to be as depressed anyway. So we haven't looked into the effects, which would be more serotonergic or dopaminergic than with this drug. It's something we do want to look at in the future because many people in pain are also on antidepressants. And our contention is once you're out of pain or your pain is greatly reduced, you might no longer need the antidepressants. But it is a good question and something we're going to follow up on.
Will the prescription drug be available in a pill, and will there ever be an OTC form like cobroxin in a pill form? Why is it in a spray form in the first place?
It's actually for packaging purposes for the most part. We don't want people to play with powdered cobra venom. The fact is, if we have people manufacturing with powdered cobra venom, that could be highly toxic. If it gets in their eyes, if they have an open cut on their body and it gets in their body, it's much like being bitten by a cobra. And so by doing a high dilution of the cobra venom and keeping it in solution, it becomes a much, much safer product to use, and it's completely safe for the end user. It doesn't mean that we haven't looked at other dosage forms. We've looked at nasal spray. We've looked at capsules and tablets and soft gels. And chances are sometime in the future we'll come out with alternative dosing.
So the prescription form coproxin is also subject to homeopathic guidelines and not FDA phase 1, 2, and 3. I think you explained that. Yeah. Okay. Do you have a necessary budget to market coproxin?
Well, coproxin, as I said, is being marketed by a third party, and they've budgeted the launch through third parties through their own fundraising. And I'm not really at liberty to say, the kind of money they've put in. They've already put in really about $1 million with purchased ads and rolling out the website and rolling out the advertising through the end of the year. But they are at ECRM. They rolled out their marketing plan, and it was an $8 million marketing plan through the first 4 to 6 months.
Okay. Someone is asking, can we get this earlier than late October or early November?
No, the problem is that we had samples. We gave out well over 100 samples of the ECRM show to buyers and prospective buyers and vendors. And we are making some more samples, but all these samples are already tagged to go out to regulatory bodies in different countries, to go to buyers and vendors. So there's just not going to be anything available until around October 17th.
Okay. Okay, here's a good question. Rick, you've mentioned this yourself to me. Rick, have you tried the product yourself, and how did it work on you?
I use the product every single day. I've had chronic back pain ever since an auto accident when I was 22, and I'm currently 41. And it comes and goes. It depends on my physical activity. It depends on things like it's much worse when I take long flights or when I drive and drive a long distance. And for those of you who know me, I'm always on a plane. In fact, just this month I'll be in Las Vegas, September 25th and 26th. Then I'll be in Taiwan, September 30th through October 4th. So I do a lot of trips. I've done tours in Australia and Hong Kong through southern China. I'm in Japan several times a year. And so I'm always on these long flights. And sometimes the pain's been absolutely excruciating, and I just will not take an opiate. I won't do it because I need my brain for what I do for a living, for my public lectures, for my writing tours, for my investor conferences. And so I really can't afford to take any kind of opiate. So my thing has always been, sparingly NSAIDs, things like Aleve. I used a lot of topicals, for example, BioFreeze, which is a lidocaine topical. Mm-hmm. BioFreeze works amazingly, but if you use it constantly all the time, it actually starts to numb the skin to where you can't even feel it anymore, and it can irritate the skin over time as well. Mm. And so we really, I needed something else, and I started using the Coproxin about 3 months ago, and it's been an absolute miracle for me. I've gone back to working out. I run on a treadmill every single day. I bought my own treadmill for my house. I work out 2 to 3 times a week. I've already lost about 12 pounds since I started using the product. Not that the product is for weight loss, but it's allowed me to be much more active. Mm-hmm. It's been fantastic. And my assistant is a wonder. Nina Goldstein is my administrative assistant. She was taking shots of cortisone about once a month. She could barely move. She had to have a special chair and things like that. Since she started using the Coproxin, she rides her bicycle every single day. She rides around the neighborhood. She's been working out as well and been much more physically active. And that's the big problem. I say we keep running out of samples. I can't show her that I have a bottle because she'll take it from me. And so it becomes really hard to hold on to this stuff. I can't wait until we have a commercial batch.
Oh, yeah. Well, that's a great testimonial because, I mean, it has to work for you if it's going to really work for other people. I think that's great. Talking about samples, has any thought been given to giving pain clinics and doctors samples to give out to patients?
Yes, we have talked about that. In fact, we're talking to a pain clinic now in Washington State, and they're actually going to conduct one of our clinical studies. And we've talked about creating a subsidiary charity where we could provide the drug free of charge, or certainly, or at least at a discount, to pain clinics to people that need.
Rick, you can type in the chat box anytime you feel like you're getting tired and you want to go to bed. Okay, just let me know.
We did schedule till 10:30, so we have a few more minutes.
Okay, we have a few more minutes, folks. Sorry, so these questions will not. Some of them will not be covered, unfortunately. Menstrual cramps, it helps. I think you mentioned that it does help with menstrual cramps. Folks, the price again is $20 for the spray, which lasts for about a month. Does it interfere with sleep?
No, it greatly improves sleep. I mean, the stage 2 pain is categorized as that which interrupts sleep or work. And so what we found is that people are actually sleeping through the night. They feel much better, and especially if you take it just before bed, you just feel wonderful in the morning because you don't have that cramping up and everything that you can normally experience if you have chronic back pain or head and neck pain when you stiffen up and you just can't get up in the morning.
Where do you get the cobras from? Where are they farmed?
Now that is a wonderful question. We do have 3 validated farms in the United States, and that should certainly supply the launch and bring us through the first 6 to 12 months of product production. We are trying to validate farms in Asia as well. There's the main cobra we use is Thailand monocled cobra, and there's farms in China and in Taiwan, and in Thailand. And then additionally, we are it's a natural product, and so we have to raise additional cobras as the market bears. So someone even laughed the other day and said they're going to start a cobra farm just to cash in. I wouldn't recommend it. They're not the easiest things to raise.
Well, can't you genetically engineer the toxin itself, the venom?
Yeah, well, no, not really. We actually have cloned the genes for certain peptides. For example, alpha cobra-toxin, and we can synthesize that, and we can ferment that as well, grow it in bacteria. But this is a mixture. The cobra venom that we're using is a mixture which follows homeopathic guidelines. And so it would be impossible for us to synthesize exactly this particular mixture. Now, understand this, too. For people not in the pharmaceutical industry, it's not unusual for a company to depend on a natural product and a natural product production. And I'll give what is probably the sickest example is the drug Premarin. If anyone ever heard of Premarin, it was used in postmenopausal women to greatly reduce symptoms of postmenopausal syndromes, which included hot flashes and arrhythmias and things of that nature. Well, it was called Premarin because it's from pregnant mare urine. It would actually collect urine from pregnant horses, and they would purify the hormones from the pregnant mare urine. And I can't tell you, there was no one on a conference call saying, how'd you get the mares pregnant, and how do you keep them pregnant, and how much urine is there, It's not unheard of to use a natural product for a successful pharmaceutical. This is just something a little different because, for the most part, people use single compounds, and we're using a mixture.
Got it. Can investors get a sneak peek sample of the product?
A sneak peek sample. Well, again, we really don't have any samples. If they want a sneak peek, all the information is on the Cobroxin website at cobroxin.com. But I understand what you're saying. I mean, people have invested in the company and they've begged me for samples. I just don't have any. So as we produce them, if you catch me when I happen to have a bottle on me, I'll make sure that you get it, especially if you're in desperate need for it. But understand that it's going to be commercially available at the end of October.
Well, I think we should get you back on just before it's released, so we can let people know that it's ready.
Okay. I'd love to. I'll come back on. I can give you any further information, things I might have missed. We might invite Dr. Paul Reed on the line, who actually conducted the clinical research, and he could answer a lot of these questions much more in depth than I did.
Okay. Someone says, I guess we're going to have to wrap this up now, but someone says, is the two-headed snake still your mascot, and is it still alive?
Sadly, the two-headed snake, passed away. David Isserman could tell you more about it, but it is true. A few years ago, there was a two-headed snake that made all the talk shows. He was on Good Morning America and the Today Show, and we sponsored him for the World Aquarium, which I believe is in St. Louis. Our sponsorship it was a charitable contribution, but we basically sponsored the two-headed snake, and he did pass away, I think, more than a year ago, but we is sorely missed.
Oh, was that a cobra as well?
It was not a cobra, no. It was just a kind of, I don't even know what kind of, it was basically a garden variety snake. It was not a venomous snake, but it was funny because the two heads would fight over food and things like that. It would actually, it was like two separate creatures.
All right, well, this has been great. Thank you, folks, for joining us. Rick, thank you very, very much again for this informative webinar. We wish NutriPharma the very, very best. I mean, I can see you guys are going to go blast this thing out of the orbit for sure, and it's going to help a lot of people.
Well, thanks for having me, David. It was a pleasure as always.
Thank you. All right, folks, you guys have a great night, and see you next week on Tuesday. Good night.